Hello, everyone. Welcome. We're going to talk today about guided by flow, stroke volume directed therapy, and how it reduces mortality. My name is Angela Craig, and I'm a senior medical manager for Baxter Medical Affairs. I still work at the hospital one day a month at Cookeville Regional Medical Center in Cookeville, Tennessee, and I am a Sepsis Alliance Advisory Board member. I am bringing this talk to you as I gave this talk as a booth talk at NTI this year, so I hope you enjoy it. We are going to review and analyze recent literature that has shown a decrease in mortality when utilizing stroke volume guided therapy. And we are also going to look at a case study and review how to apply stroke volume guided therapy in multiple settings. So what does stroke volume directed therapy even mean? Well, I'm glad you asked. Well, what we can do is we can do what's called dynamic assessments. And we can determine if a patient has an increase in stroke volume, which is the amount of blood with each ejection, with each heartbeat, right? And you can determine if that patient has an increase in stroke volume when we give them fluid, whether it's through a passive leg raise or a fluid bolus. Now, why is that important? Well, we are looking here at volume, at stroke volume, which is more of our flow parameters, right? We're not just looking at pressure. So we look at a patient in a situation that has maybe hypotension or hypoperfusion of some way, shape, or form, and we do a dynamic assessment. Now, how do we do a dynamic assessment? Well, we can do a passive leg raise, and in order to get a stroke volume number, you would attach them to whatever technology it is that you're utilizing. The technology that has the ability to give you stroke volume and stroke volume index, cardiac output and cardiac index, right? And they have those available now in non-invasive forms. And what we do is we do a baseline assessment. Baseline assessment for about 3 minutes or so, and then the monitor will tell you when to lay the patient flat and we lift their legs. When we have the patient elevated initially, though, for the initial baseline, we have them in what's called a semi-recumbent position, as high as that head can be to really decrease that volume from their heart down to their lower extremities, so that when we lay their patient flat and we lift their legs, that volume will fly into their heart and just challenge it really quickly to see if they have a 10% or greater increase in stroke volume. If they do, that means they're fluid responsive, which means their heart can take and receive at that moment the volume to help forward flow and improve perfusion. Okay? Now, the other way we can do that is to do a fluid bolus. And that would be there's two sizes of fluid boluses that you can do to test this. We would still do a baseline 3-minute baseline. However, you don't have to have the patient in that semi-recumbent position. Whatever position the patient is in is fine, but we just recommend you keep them in that same position. And then we challenge the heart by giving either 250 in less than 5 minutes or 500 in less than 10 minutes. Now, when we challenge the heart, this is where we are putting it on a pressure bag and putting it in as quickly as possible, right, into the patient. So this is faster than 999 on the pump. This is through the pressure bag and trying to get it in very quickly. Now, just so you're aware, and this is a little alarming to me, that only 50% of patients who are hemodynamically unstable are fluid responsive. This has been tested, which means that only 50% of patients may benefit from additional fluid resuscitation, which means 50% of the patients won't benefit from additional fluid resuscitation. Well, most of us probably in the ICUs we work in, we usually give fluid automatically when a patient starts dropping their pressure, right? So I want to challenge you that not all patients' hearts can take and receive that volume at that moment to help forward flow and improve perfusion. So what do we do with these results? Well, if they are fluid responsive, greater than or equal to 10% in stroke volume or stroke volume index, then additional fluid will most likely improve perfusion. And we would use that data, of course, along with other patient assessment data, and we would give fluid usually to improve perfusion. However, if they are less than 10% increase in stroke volume index, that means they're not fluid responsive, and additional fluid is unlikely to improve perfusion. So we would look at things like cardiac index, total peripheral resistance, total peripheral resistance index, to see if vasopressors or inotropic support is needed. So now let's look at some of the data to support this individualized care. I mentioned we were going to talk about mortality benefits of stroke volume guided care. In this particular study, there were 13 trials that were enrolled and about 1,652 patients, and they incorporated dynamic assessments of fluid responsiveness into goal-directed therapy. This was a systematic review and a meta-analysis, and the conclusion was that in adult patients admitted to the intensive care who required acute volume resuscitation, goal-directed therapy guided by assessment of fluid responsiveness appeared to be associated with reduced mortality, ICU length of stay, and duration of mechanical ventilation. And it does go on to say high-quality clinical trials in both medical and surgical ICU populations are warranted to inform routine care. In this particular study, this was from the Kansas University, and they looked at dynamic measures in sepsis, and they had a stroke volume guided fluid resuscitation group in severe sepsis and septic shock, and then they had a usual care group. And this was a retrospective cohort study. And you can see here that they had a reduced fluid balance in the group that utilized stroke volume guided fluid management, reduced ICU length of stay in that group, as well as used less vasopressors, had less mechanical ventilation, and less dialysis. And what they found is, once again, that about 53% of patients were fluid responsive, which goes along to our previous study that showed pretty much the same thing. So after this Kansas study was done, you can see here the fresh trial was done in 2020, and that is the fluid response evaluation in sepsis, hypotension, and shock. And this was a randomized clinical trial. And what they did was they looked at patients who are hypotensive or hypoperfused, and if the decision was made to treat the patient with either fluid or vasoactive medications, they had specific criteria there, as you can see. Then what it did was this triggered this algorithm. So they would do a passive leg raise to determine if they were fluid responsive or not. If they were not fluid responsive, they had a less than 10% increase in stroke volume, then they titrated pressors immediately. And you can see they had a little algorithmic choices over there. Now, if they were fluid responsive, greater than 10% increase in stroke volume, they went ahead and gave a fluid bolus, and then they reassessed. And I think this is a really important point, the reassessment to determine if the patient has adequate perfusion. If they do, we'll continue to observe. But if they don't, if they're still hypotensive or appear hypoperfused, then we are going to go back and do another passive leg raise, a fluid responsive test. And that's what they did here in this study. And what they found was very similar to the KU study, that the fluid balance at 72 hours or ICU discharge was lower in the stroke volume guided group, less renal replacement therapy, less mechanical ventilation, less ICU length of stay in the stroke volume guided group, and more patients were discharged home. And even though not every one of these were statistically significant, they are all very clinically significant. This particular study talked about the use of bioreactants in rapid response assessments. And what they had was they had two groups. They studied a group without the use of stroke volume guided fluid management. And so they call that on their study the pre-Starling group. And so the pre-Starling group is also the ones that we use bioreactants. So just so you're aware, the Starling system, aka Cheetah, or people call it the NICOM, that is what's using bioreactants. So I just wanted to share that so you understood what system this study was using. And you can see here that bioreactants group, meaning they did not use bioreactants, versus the group that they did use bioreactants, you can see that pretty much these patients ended up having sepsis, a large percentage, 92% and 85%. Now, this wasn't necessarily meant to be a rapid response, it was meant to be a rapid response study. It wasn't necessarily meant to be a sepsis study, but you can see here that a lot of the hypotensive patients that they went to see on the floor were septic. And here you can see that the The group that they used the Starling on had a little bit of a lower blood pressure and lower mean arterial pressure as well. And what they did was they looked at patients who were suitable for goal-directed fluid therapy with IV fluids. They started a bolus, and then if the patient was fluid responsive, they gave fluid. If they were not fluid responsive, they considered other treatments for hypotension. And you can see here that these patients had less fluid. The group that they used stroke volume guided therapy on, less fluids were given 24 hours prior, and also less fluids post fluids less were given, as well as the ICU admission rate was much less in these stroke volume guided fluid management group. You can also see here that there was much less RRT or CRRT, much less patients needing ventilation or CPAP or BiPAP. And also, you can see here that actually they did have a few more hours of vasopressors, which it might just be related to the fact they had a lower blood pressure, but it looks like that's what they needed since they were utilizing this technology. And then you can see here with their survival, this study was really underpowered for mortality. It was not clinically significant, and the sample size was really too small to detect changes in outcomes as complex and multifactorial as death. So they focused on those intermediate things such as CRT, rapid response, CRT, etc. This particular study was the Association of Non-Invasive Bioreactance Monitoring with Hospital Mortality in Adults with Sepsis, the results and the mortality outcomes. And you can see here that bioreactance use was associated with 3-day mortality decrease, hospital mortality decrease, and high-risk patient mortality decrease as well. This particular systematic review and meta-analysis had 9 eligible RCTs and 698 patients. And this particular study looked at dynamic measures of fluid responsiveness to guide resuscitation in patients with sepsis and septic shock. And what they found was in adult patients with sepsis and septic shock, using dynamic measures of fluid responsiveness may improve survival and reduce the risk of AKI. I also want to mention here that in the updated guidelines from Surviving Sepsis campaign, you can see for adults with sepsis or septic shock, they suggest using dynamic measures to guide initial fluid resuscitation over physical exam or static measures alone. And that recommendation did increase from the last guidelines. So let's talk about the 3 levers of perfusion and talk about how this can help us care for our patients and have better outcomes for them. So remembering it's all about perfusion with our patients, right? So pressure is just that, it's a pressure. Not that it's not important, but it's important to think about more flow. So we're going to be looking at our cardiac output, our stroke volume for our flow parameters. The first lever of perfusion is preload. Looking at stroke volume and stroke volume index, think V for volume. Normal stroke volume is 60 to 100. And so think normal heart rate to get those ranges right. All right, we are going to perform dynamic assessments to assess if this patient is fluid responsive, and that's going to be our preload lever. The next lever is afterload. Total peripheral resistance index. And basically, this is the non-invasive surrogate for SVR. So think R for resistance. Normal is 800 to 1200. The lower the number, think the more vasodilated. The higher number, think more vasoconstricted. And the third lever is contractility. Cardiac output, cardiac index, think C for contractility. And if it's low, you want to ask why. Does this patient need fluid? Does this patient need an inotrope? And we also know that part of contractility is looking at stroke volume as well, but we've kind of already looked at stroke volume and stroke volume index to see if fluid is the issue. And now we're going to see if we still have continued low stroke volume, we're not fluid responsive, and we have a low cardiac output and index, we're going to think about potentially an inotrope. All right, so let's do a scenario. So we have a patient who's 5'4", 160 pounds. They arrived to the emergency department with a cough and fever times 5 days. The patient is sent for an x-ray and the diagnosis was made. The patient has bibasilar pneumonia. Now, the patient is febrile with 101.5 temperature, heart rate's elevated at 110, respiratory rate's elevated at 26, blood pressure is low with a MAP of 55, white count is elevated at 13,000, lactate is elevated at 5, procalcitonin elevated at 4, and creatinine is elevated at 2.5. So the patient is placed on the non-invasive hemodynamic monitor to assess the patient's heart ability to accept and receive that volume at that moment in time to help forward flow and improve perfusion. All right, so look at stroke volume. Normal is 60 to 100. This patient is 50, so our stroke volume is low. TPR is right at 800. That is the low part of normal, 800 to 1200, and cardiac index is 3.1. So we ask the question, is this patient hypotensive or hypoperfused? Yes, we are hypotensive. We only have a 55 MAP. So this patient deserves a dynamic response assessment. So we are going to assess them for fluid responsiveness. So you can see here, we can either do the passive leg raise or a quick fluid bolus with a pressure bag. So after this is done, you can see here that the patient had a 12% increase in stroke volume. So since this patient is fluid responsive, what might we want to give this patient? You can look at your choices there. We could give a pressor, an inotrope, give balanced solutions, or give a nitrate. I'm hoping you all picked give a balanced solution. So we give a balanced solution of 500 ml since the patient was fluid responsive. And our question is this patient still hypotensive or hypoperfused? You can see that the mean arterial pressure is only 60. Stroke volume is still is 60, so right at that lower level of normal. But since our mean arterial pressure is only 60, we're going to go ahead and do a passive leg raise or a quick fluid bolus with a pressure bag. And what we find is that this patient has a 3.3% increase in stroke volume. So is this patient fluid responsive? There should be a resounding no. So what might we like to give since this patient still is hypotensive? We are going to add a pressor. It's been 1 hour and the patient's MAP is now 70, and we ended up maxing this patient out on Levafed, and we want to look at these hemodynamic changes. Now, our question is this patient hypotensive? That answer would be no, right? Because we have a mean arterial pressure that's up to 70. But what has that vasoconstriction done to our TPR? It's increased that up to 1600, right? So we are really constricted. And what does that do to the ability to the heart to pump against constriction? Sometimes that really decreases that. So as your TPR goes up, many times your cardiac index goes down. So you can see we're at a very low level of cardiac index. So yes, we are still hypoperfused. So we do another passive leg raise or quick fluid bolus. And what I want to share with you, the hemodynamic changes. Notice that, yes, if we are 100 heart rate, 70 MAP, we may think this patient is totally fine, right? But when you have a patient connected to hemodynamic monitoring, you see that really it could be detrimental, right? This patient had a high TPR and a very low cardiac index that we would have missed had we just looked at heart rate and MAP, right? So this patient had a 6.6% increase in stroke volume. So since the 6.6% increase in volume is not fluid responsive, what might we want to start on this patient? We are going to add an inotrope. And by adding an inotrope, hopefully we can help that patient pump against that constriction. And that should help that patient balance out that total peripheral resistance and increase that cardiac index. So, in summary, stroke volume guided fluid therapy can make a difference. Become an expert in hemodynamics. Quit guessing, have a scientific approach. I hope you've enjoyed this short lecture, and I want to remind you that we do have this medical education website. It is www.fluidmanagementeducation.com, and there it's loaded with all kinds of education as well as podcasts and videos for you for your medical education. There are multiple references for this presentation. And I just want to thank you. And if you have any questions, feel free to email me at Angela_Craig@Baxter.com. Thank you.